broadcast is now starting. All attendees are in listen-only mode.
Good morning, afternoon for some of you. Thank you for joining our webinar, Practical Solutions for Cal OSHA COVID-19 Emergency Standard Compliance. Today's webinar is hosted by Matthew Gehman, Director of Internal Risk Management at Eurofins National Service Center, Dr. Michael Berg, Technical Director at Eurofins EMLab P&K, Brian Dillon, Business Unit Manager at Eurofins Fremont, California, and Jeff Oliva, COVID Collection Services Specialist at Eurofins Clinical Diagnostics. I'm Genevieve Randall, and I'll be moderating today's webinar. Before we begin, I have a few notes about today's webinar. The broadcast is being recorded, and you'll receive the recording and a copy of the slides via email within 3 business days. We'll follow the presentations with a live Q&A session, during which you can submit your questions for our speakers. To submit your questions, use the GoToWebinar sidebar menu. Select the Questions tab, type in your question, and hit Enter on your keyboard. You could submit your questions throughout the webinar. We'll follow up with any questions we don't get to during our Q&A session after the webinar. All right, now I'm going to pass it off to our first speaker, Matt.
Thanks, Genevieve, and hello, everyone. I'm going to start off with just a very quick high-level overview of the COVID-19 emergency temporary standard that was signed into law for California. Genevieve, I'm not able to advance here. Thank you. Okay, so starting off with a quick high-level overview again. And many of you are probably well aware of this standard and the scope and the timeline of it, but I'm going to cover it briefly up front. So the standard itself applies to all California employers, employees, and places of employment, with 3 exceptions. So those employees who work alone, those employees who work from home, and then any employee that's covered by the aerosol transmissible disease standard. And so some examples of businesses that are typically covered by that standard are hospitals, clinics, laboratories, and long-term healthcare facilities. Despite those exceptions, it's important to note for the aerosol and transmissible disease standard that there may be portions within those types of portions of the population within those types of facilities that are not covered and the emergency temporary standard would apply to those. So some examples of those are your IT department, any administrative staff or other staff that aren't working in an environment where airborne transmissible diseases are a hazard. And so the timeline, the standard became effective on November 30th. There was a lot of pushback by businesses in the state of California, and Cal OSHA pulled back on enforcement and penalties until February 1st, provided efforts are underway in good faith. So that's important to keep in mind. February 1st is not that far away, though, for employers to be in full compliance. The duration of the emergency temporary standard is 180 days, so that runs us through May 29th, and it can be renewed up to 2 times. Okay, so we'll cover just a couple of the key program elements. At the heart of the standard, employers are required to maintain a written program with certain elements. First of which is, how you're going to identify and evaluate COVID-19 hazards. And so just some examples would be employee health screening as they enter the building, inspections. Another one I didn't include here, but we'll cover later in the presentation, would be surveillance testing. So definitely pays to think up front on how you're going to have an ongoing evaluation of hazards as the pandemic progresses. Also, how you're going to correct COVID-19 hazards. So you have to assign responsibility for your controls, outline reporting processes, and then establish controls with the hierarchy of controls in mind. So engineering controls first, administrative controls second, and use PPE as your last resort. You also have to have policies addressing COVID-19 controls. So what controls are you going to implement? And of course, there's a lot of common examples which we're all very familiar with at this point, such as telework, distancing, physical barriers, staggering your shifts, and so on. Can we jump to the next slide, Genevieve? Thank you. Some additional program elements. You have to have procedures in place for investigating and responding to COVID-19 cases. So you have to outline what that reporting process is, how employees are to do it. And you also have to test staff. So again, there's a whole section on this a little later in the presentation. So I'm going to kind of skim over that point. In terms of your system for communication, it has to be a reprisal-free process. And you essentially have to outline how staff are supposed to inform you and how you're going to inform staff. So you want your staff to understand under what conditions they need to notify you of a situation and what information you're going to need. And when you look at it the other direction, they need to be aware of the means that you're going to use to communicate things to them that they may need to know, such as an outbreak at the facility, or how to get a test, or what their benefit and leave options are, and so on. The other important part of the standard here is you have to train and educate your staff. You have to actually take time to train them on all the different elements of your written program. We can jump to the next slide, Genevieve. Another key provision within the regulation is the exclusion of infected or compromised staff from the workplace. And it really does kind of follow with the public health guidance that on this point that has been around since the beginning of the pandemic. So currently that means a 10-day isolation if somebody is infected, a 14-day quarantine if somebody is exposed. And then the final 2 points I think are just good practice. Know what you're going to do if somebody has some symptoms but no test, and also what you're going to do if somebody has traveled and they're also at risk in that way. And then the final point here that's required within that written program is a section on reporting, record keeping, and access to records. We're gonna cover that a little bit later in the presentation, but I included it here because it is required within the written plan. We can jump to the next slide, Genevieve. Thank you. Which leads us to what happens if you fail to adhere to the standard. So in California, you could be subject to some pretty steep fines. And I did some digging a little earlier this week, and I did note some fines. I didn't actually dive into what the actual violations were, but the penalties were about $40,000 for violations related to this. So they are out there finding things, something to be aware of. The hidden danger to me is claim costs. What are the long-term costs of this? And it's really going to depend on your insurance program. Certainly a point that you should consider. You should definitely understand what your insurance program structure is, how high are your deductibles. We don't really know what's going to happen in terms of liability claims in the future. But if you do have someone that's infected in the workplace, it is compensable by workers' compensation. And whether or not you have deductibles on your program or not, those losses will cause cost to hit your business, either in terms of future premium or immediate direct costs related to your deductibles. So just another thing to kind of keep your eye on and at least be aware of. And as we know, if we end up in liability claim territory, they can get very expensive. And we can jump to the next one, Jennifer. Thank you. One key point on vaccinations, currently there's no relief for vaccinated staff from the rules. So I think that's an important thing to point out. Rushing your staff in to get vaccinated to sort of avoid having to comply with the standard won't do you any good. You still have to comply with the standard. And then I finally just included a resource link there, which I'm sure you're all aware of. But that does it for me, Genevieve.
All right, thank you. We're going to move on to Brian Dillon now. All right, you should have controls.
All right, thank you, Genevieve. Greetings all, my name is Brian Dillon. So I'll be going through really from the employee perspective out here in California, how these the OSHA standards, how the employer essentially translates those concepts into actions and communication plans within their facilities. So really just a high level of the major sections within this emergency temporary standard. The three I'll be discussing with respect to specific details on the employer side is going to be the COVID-19 prevention, multiple COVID-19 infections and outbreaks, and then major outbreaks. The other two in the section are more specific to certain lines of business where the employer is either providing housing or transportation. However, very similar concepts to the first three are listed within those two sections. Okay, so the first, in the prevention section, it's very important just to understand the working definitions that have been laid out from this temporary standard. And so COVID-19 symptoms, temperature of 100.4 degrees or higher, cough, chills, fatigue, and there's actually a list. And this list is important because it also corresponds to a lot of the ICD-10 codes that have been listed underneath the COVID testing for insurance companies. And so if you ever go to a collection site or orders, you'll note that a lot of these symptoms are already listed out. And so California defines them within this emergency temporary standard. High risk exposure period. If there's no testing going on, but let's say there are symptoms as the noted above, what is the time frame the employer is expected to have that person quarantined from work? And then also, who could they have possibly exposed? And so the time frame they've recommended is 2 days prior to symptoms or a positive test to 10 days after symptoms first appeared or a positive test. And 24 hours have passed with no fever. And so this is really the essentially the parameters. They said if you have somebody that exhibits these symptoms or they declare to their employer that they have tested positive, this is anyone that's had exposure to this individual within this parameter is somebody that needs to be quarantined themselves or either assessed if they had the appropriate exposure. And what is that as far as like what is meaningful or significant contact? Is COVID-19 exposure a person within 6 feet of a confirmed individual, a confirmed COVID case for 15 minutes or greater in any 24-hour period within or overlapping high-risk exposure period. So what does that mean to an employer? Essentially, if I have somebody that's tested positive and I had individuals working within their immediate work group, such as a cluster of office spaces within that distance, or it's just reasonably assumed that they had about 15 minutes of close contact with that individual, they would be considered part of that cohort of COVID-19 exposure. If somebody that's transiting through an office space, that would be once again up to the interpretation of the employer. However, unlikely they meet the definition of an individual that's been exposed. This is particularly important for manufacturing facilities that have shifts, where if they have overlapping shifts, they can jeopardize their shifts. If they have people working together for a long period of time. So we've seen a lot of shifts kind of separated now, or even have a very minimum overlap, so they don't meet that definition. And also schools as well, and how they essentially move from class to class if they're back in session at this point. Now, how do they define a COVID-19 case? Well, it's a positive COVID test. You move one down. A COVID test is defined by California as an FDA EUA for either antigen or PCR. So the test has to have an EUA, and it's either one of those two categories that meets the definition of a positive COVID test. And then the last part of this prevention section requires employers to have a written COVID-19 policy. And this policy should have a communication framework. How are they addressing these particular issues in the workplace, and how are they communicating to employees, and what are they doing if there is a positive employee in their work group and there's others that have been exposed? How does that communication plan work? Multiple COVID-19 infections and outbreaks. Employers must notify public health departments when the following requirements have been met. There is really a specific number, it's not a percentage, So larger organizations are going to have more challenges with this, but 3 or more cases in a workplace in a 14-day period meets the definition of an outbreak. 20 or more cases in a 30-day period meets the definition of a major outbreak. The difference between those two is going to be how much testing is mandated to them. So 3 or more cases within a 14-day period, there's immediate testing that's provided to all employees in the exposed workplace. Once again, keep in mind that definition, exposed workplace. So if it's a 5-story building and you have one department, it's understood that unless you had individuals from that department that met that 15 minutes within 6 feet or longer of individuals that were in that exposed cohort, they're not expected to conduct testing. However, that testing will go on until they no longer qualify for that definition of 3 or more cases, excluding the positive cases, of course. Major outbreaks, the difference there is the frequency of testing will be twice a week for a 14-day period, once again, until they no longer meet that outbreak criteria. Now, the major differentiator is the employer is not required to provide on-site testing. So they don't necessarily have to have collection teams show up to their place of employment, but they must provide an opportunity during working hours and compensate employees for travel if they so choose to go to a community testing site. Once again, the employer still must provide free testing. So they cannot have the employee use their insurance, and if they're going to a community testing site, it's expected that that testing is free, but once again, they will have to compensate for travel. Okay, so as far as client interpretations of this, so a lot of businesses in California really have kind of looked at 2 separate models for how they are looking at this emergency temporary standard. There's the preventive model, which is really they have a certain portion of the workforce or class that is work remote and others on site, and they are testing a rotating percentage of the workforce. And this allows them to mitigate any potential outbreaks by checking certain percentages of the workforce. If there is somebody that's positive, they're removing them from the workforce and they're continuing to test. The second model is really a contingency model. They're anticipating a return to school or work. They do not want to conduct testing, but want to be prepared. Now, this one is interesting because it is kind of your classic a doom loop sequence. They don't want to conduct testing unless they need to because there's a positive. However, they won't know there's a positive unless individuals are being tested. And then if there's enough people that are tested, they're going to have to test the entire workforce. So in both models, there is a recommendation to have a baseline test to establish whether or not there is any kind of prevalent outbreak or major outbreak within that workforce. However, this is generally the 2 models I've seen, at least in the California area, with regard to school and manufacturing plants. So last thing, additional notes, return to work criteria does not require a negative test. So kind of going back to that previous definition of after 10 days and 24 hours of no fever, that individual can return back to work. So there's no requirement for them to take a return to work test. And that's specifically mentioned within the emergency temporary standards. Discuss the exposed workplace, the common work area of a cohort, not the entire building. However, once again, this is on the determination of the employer. So they may want to check because they're not sure who has actually passed through that area. And lastly, employers must contact the local health department if 3 or more cases have been identified in their workplace. So this is something that, regardless if there is a laboratory support or not, that is reporting to the state, that OSHA does want this reported as a safety incident, and it is going up to the public health department as well. So there's really two channels of communication, one from the employers, and then obviously from the laboratory that's conducting the testing to the public health departments. Okay, that is all I have.
All right, thank you. So now we're going to move on to our next speaker, and that is Jeff Oliva. Jeff, you can go ahead with your presentation.
Thank you all. I appreciate the time and the opportunity. Yeah, I've got a long history in healthcare, and I think a lot of people that are in the COVID hotspots right now and having to make decisions don't have that background. And I feel for you. It's complex. So what we try to do is find ways for you to hit the easy button when it comes to executing these testing plans. So we're going to talk a little bit about the COVID-19 collection options and modalities. They have evolved a bit, and we can cover that. What to expect from a collection partner from start to finish, how to choose the right collection partner and provider, COVID-19 testing payment options, and applications of actual testing programs. So on testing and collection. Brian mentioned earlier that an EUA test is required. And an EUA test is an emergency use authorization that's granted by the FDA. Laboratories who get these authorizations must submit their testing for approval to the FDA. And all the testing that we're talking about today does have that EUA testing approval. There is the PCR test, which is considered the gold standard. It detects the actual DNA, genomic material, the RNA of the virus. It is the gold standard for both sensitivity and accuracy. And then antigen tests detect a protein component of the virus. They tend to be those rapid tests that you hear about that can be done in 15 minutes. Not as accurate as PCR, but they do play a role in the overall testing plan. And I think the good news for anyone being tested is the old brain tickler, the nasopharyngeal swab, has been complemented with some other collection methodologies, including nasal swab. So instead of going all the way back in your sinus cavity or your employee's sinus cavity, it's just simply the tip of the nose now, the nostril. About a length of a Q-tip in there is collected and then put in the vial for RNA testing. There are also saliva testing modalities, a little more difficult for people to produce and not as time efficient, but it does work. Not quite as sensitive as the nasal swabs. And then pooled testing, which is where multiple employees are in the same pool test. It's more of a cost-effective way to test, where you can get 5 to 1, and that works if there's not an outbreak in your area. If there is an outbreak in your area, it's less cost-effective. As we talk about California, much of the state's in a pretty significant outbreak, but pooling is an option. So how do you consider the specimen type? Obviously, age, health of the patient, any existing medical issues. I can tell you that most people can do the nasal swab or the saliva. It's very easy. We even do small children, infants, even with the nasal swab. It's nice to have that option now. Again, that was not available at the beginning of the pandemic. So RT-PCR is it's the process of copying or amplifying DNA and RNA for diagnostic use. Just like your cells can copy DNA and RNA, the laboratory can replicate that using instruments. And several billion copies of a specific piece of DNA or RNA are made for scientific analysis. And those floating RNAs, if you will, find the virus's matching RNA and make the diagnostic positive or negative conclusion. So this used to take a very long time. I remember when it was invented, and it is a breakthrough technology. What's great about it, it's almost 100% sensitive. So if it is a positive test, it's 97% chance that it is positive. And that accuracy is unique to PCR. So I mentioned the easy button. How do you implement your program? How do you get specimen collection achieved? I think you really need to work with your partner on a bespoke or a customized strategy and plan. What are the goals for your testing plan? A lot of those can be determined by the OSHA rules and what you want to accomplish in regard to meeting Cal OSHA standards. Obviously, the pandemic status in your geography is very important. You have to consider the positivity rates, as I mentioned, around pooling or around getting people together, for a testing event, because there is some risk there. There's also how frequently you should test and the number of individuals you want to target with the testing. In addition to pooling, there's a cost-effective worn mask testing capability as well, where everybody, 10 employees throw their masks in a bag that those masks are tested, and you know that it's not a diagnostic test, it's a sentinel test on the environment, but it tells you there's virus in the area. And again, can also be a very cost-effective way to monitor the population after that initial testing event. Then what's the community impact on your testing? What are you going to do next? Are you going to offer contact tracing? What quarantine guidance? Of course, all this is available from the CDC and from Eurofins, but that whole thought from beginning to end on how you would execute a program is important to sit down and plan out. And then from a collection standpoint, if you're going to have a testing event, there are several options. You have a drive-through, of course, that everyone sees on the news. Some drive-throughs are slower than others, but they can be run very efficiently depending on your space and your population, what time they arrive, that kind of thing. So if it's a specific shift, that can be managed. Same with walk-up. So if you have socially distanced walk-up, you don't have the traffic issues. You don't have cars going out in the street and the LA police contacting you or local police contacting you because you clogged traffic. It's a way to get people to park and then come up and be called out of their cars and be tested individually, again, in a safe way. If there's a company clinic or a retail facility, you can obviously do walk-in testing. It's preferred to do outside or in a large warehouse, what have you. And then there are home kits. So self-collection at home, take a kit from work, take it home, do the test at home, mail it off to the lab. So there are a lot of options there. And again, depending on how quickly you need the results, how many people you have to test, and what your particular layout is at the location, all these can be customized. And you don't want to turn your testing event into a super spreader event. So you do need to consider, if anyone's symptomatic, obviously they should not be invited to the testing event. They should be screened out. You have to plan for social distancing, have the appropriate PPE provided by your partner, all the cleaning precautions. Self-collection is an important new option for symptomatic individuals, and also a drive-through. Drive-throughs have kind of been the municipality standard because you can keep symptomatic people in their car. They only roll their window down when they're in front of the swabber. So that all works well. But the point here is you can plan this out. You can customize it to your population and your location, and really have a non-disruptive testing event, which is your goal. How do you choose a testing partner? Obviously, look for experts to help you design your approach. Make sure they have safety training and insurance. Many of these companies just spun up since the pandemic, and they have about that much experience in healthcare. You want to make sure the team you choose is experienced and recognizes both the risk from a infectious disease standpoint and also from a privacy and insurance standpoint. Somebody who really knows what they're doing and can do it efficiently. There are fewer available healthcare professionals in every geography, especially in California right now. So they have to be able to locally staff. Again, our partners have those capabilities, and we're, we vetted quite a few, so we're happy to help you with that. From an IT standpoint, scheduling, reporting, capturing consent forms, and for both privacy and the actual swab itself, important capabilities of your partner without breaking the budget. So how do you do all that cost effectively? And that's what we've been specializing in. Then once you confirm your partner and points of contacts and map out the locations, obtain appropriate clearances if required. If you're going to do a drive-through and you're going to be out in the street, again, you want to get approval. We've had to get use permits in some cases for long-term setup, but in general, if it can be conducted on your premises, permits are not generally required, but we can help you with that as well. Then sourcing and scheduling all the equipment, supplies, the PPE, security staff as necessary. The consultant period where you map everything out can answer a lot of those questions and make sure that you're ready to go when you actually hold a testing event. From a payment standpoint, as mentioned, most insurances will only pay if there's symptomatic patients, but there is an insurance possibility, and also employer paid for the testing that Brian and the team had described earlier. That's most common, is that the employer is actually footing the bill for this OSHA related testing. And with that, I'm going to hand it over to Pat.
Thank you. Genevieve, I'm still not able to advance. Thank you. All right, so we'll cover record keeping and reporting real quick. Brian had covered earlier two of the newer and more important reporting provisions. So you have to report cases to the local health department if you have 3 or more within a 14-day period, or also if you have 20 or more within a 30-day period. And there's a bunch of information you do have to provide, and that's listed there. I won't go through that line by line. Additionally, if the infection is believed to have happened at work, then OSHA and Cal OSHA record keeping requirements may kick in, and this would follow along with your typical OSHA 300 log, and provided that employee isn't able to work, and in most cases they won't be. So that's just something to point out. And the other thing I'll mention is, depending on your insurer, they may be asking you to report these cases to them as well, whether you believe it to be work related or not. I know that applies to us, so I'll just throw it out there. It's not a statutory requirement, but something that might be hovering over you. In terms of record keeping, you also have to be prepared to produce upon inspection your COVID prevention program, copies of your inspection records, documentation of corrective actions if you identified hazards in the workplace, your training documentation, and if any of you have had experience with OSHA in the past, or really any regulatory agency for that matter, the training records are the first thing they go for. So just be mindful of that. And you also have to be able to produce your case records. So with that, that's all I have.
Okay, thank you.
Yep.
Okay, our next speaker will be Michael Berg. Michael, you can take it from here.
All right, thank you very much. And thanks for the opportunity to talk a little bit about the environmental testing solutions. So this will be a little bit of a switch to a little different topic here. So, and what we're gonna do is we'll take a look at this as a layered approach to risk reduction. So of course, we heard all about the clinical testing, all the behavior and policies that we can put in place to avoid infections and outbreak, including social distancing, stay-at-home orders, etc. We can add environmental controls like air filtration, physical barriers. I mean, we all are aware by now that good airflow reduces the chances of getting infected. We can add cleaning and decontamination, which you see a lot of times with just wiping off areas, and then also sometimes you see people with the electrostatic sprayers walking and trying to disinfect areas. But then we also have a range of environmental tests that I want to talk a little bit about that can help you identify environmental risk, meaning and identify early if in your building or if your environment there's occurrence of SARS-CoV-2, and then address that early on. So we have tools like wastewater testing. We'll talk about that a little bit. The worn mask testing was already mentioned here. That's an interesting alternative. It's not a clinical test, but it's an interesting alternative that can give you an early heads up. We can help with surface testing, and we also have air testing online. Just to talk a little bit about wastewater testing, which has been very successful. This actually allows us to test a large group of people in very few samples. So we can take wastewater samples from, let's say, a building, and then identify if there's anybody in that building shedding virus through the fecal route. This has been very successful for university buildings, for example, on campus that try to, especially if you have a dorm building, you can isolate and identify where you have an occurrence of the SARS-CoV-2 virus, and then follow up with clinical testing and avoid outbreaks in the first place. It's also been used in larger populations like cities, communities, etc. So wastewater has a lot of opportunities that might be an interesting option for some employers to use. Oh, that was too far, I'm sorry. Go back one. So wastewater detection has actually been around early on, since first report right after the COVID-19 outbreak in December 19, and then we had this awareness in early 2020, and then wastewater testing came online on the market. The advantage of this is that we're actually able to identify outbreaks before clinical confirmations are typically done. So in a lot of settings, it's been shown that 4 to 10 days before clinical cases show up in the healthcare system, there have been wastewater detections of the SARS-CoV-2 virus. This one is an example from Spain, but there have been plenty since then. And if you look at the literature on that online, you'll find a wealth of information on that topic. I wanted to move on to borne mass testing. This was mentioned earlier. This has been very successful and efficient. It's not a clinical test, but we can collect borne mass from people that are breathing into the mask and then depositing virus on the inside of the mask. We can test those in the lab, and it can help identify if there is SARS-CoV-2 in a given population. And we look at it as still an environmental test. So similar to surface testing and others, we consider this an environmental test, not a clinical test. We actually use that in our own labs also for an early detection device or tool. There's an example from one of our labs in Lancaster where this has been applied with the pooled mass. So again, we collect after the shift is over, we collect the mass. We run this through our test systems. We use PCR for all of our environmental tests, and then return results next day. And then in this one case, we had a positive identification of the mass. The lab then triggers the clinical testing and identification by the clinical testing regimen, and then can isolate the cases quickly. So this may be another tool that could be very helpful for employers to use. In addition to that, we have the two test systems, air and surface testing. This goes back to thinking about how the transmission routes work. So from the infected individual, we have the direct contact, of course, that we're all aware. We do hand washing, social distancing to avoid direct contact. We can have a fomite transmission or indirect contact, so the virus can be deposited through droplets or through touching of surfaces to another individual, then touches eyes, nose, etc., and then contracts the disease that way. So we can test surfaces, in particular the high touch points for SARS-CoV-2, and then potentially identify virus in the environment and take action accordingly. Another one is the air testing. I think since the beginning there had been a little bit of a shift that we now recognize that COVID-19 is transmitted through air, and we do offer an air test to assess the if virus is in the air or not. I want to just circle back a little bit to virus stability. There has been early reports on the stability of infectious virus that was published in April 2020. And you hear that a lot, 2 to 3 days on surfaces as a common reference for infectious virus. And then in air, we have several hours of infectious virus being detected in air. Now, since then, there have been several other studies that actually confirm that the infectious virus can linger quite a bit longer, up to 7 days now in some experiments. And then virus detection in general, which may not be infectious anymore, has been found for several weeks now. So we had those cases of the cruise ships, for example, where after 17 days, there was still occurrence of or detection of virus after they had already been disembarked. So actually quite surprising how long the virus lingers in the environment. And then, of course, this may not be infectious, but we can still detect it. But infectivity anywhere from 2 or 3 days, maybe a little longer. So we need to keep that in mind. Of course, if a building is shut down for an extended period of time, we don't worry about it anymore. I want to circle back to the surface testing. So we use swabs for the surface testing, and we focus on the high-risk touch points. So meaning we look at the door handles, the elevator buttons, copier, sink, toilet, etc. So we look at those points that many people touch frequently in the building. And then, of course, those are the ones we also want to clean. So it's a confirmation that the cleaning is done appropriately, but it also lets you identify if you have infected people in that building, potentially, especially if the building is occupied by the same people. And then last, I wanted to talk a little bit about air testing. I mentioned that earlier. There has been a little bit of a shift from initially thinking that direct contact and the fomite transmission is the main mode of transmitting the disease, to now recognizing that aerosols play a role. And this is where the air testing actually becomes more important. There's growing evidence that smaller droplets and particles can transmit. And this may also mean that the 6 feet aren't enough, but at this point, a lot of the regulations were still close contact to 6 feet. We really need to also differentiate between droplets and aerosols. So droplets are when we cough, sneeze, and talk, and we produce the larger droplets that we can see on a, if I'm talking now on the screen, there's a few droplets just from me talking. Those would be greater than 5 micrometers in size. They settle fairly quickly. Those would be the close contact transmission. And then we have the smaller, what we call aerosols, or micro droplets that are smaller than 5 micrometers. They can be produced just by breathing and normal talking. So we got to be aware of that. There may be a transmission through aerosols, and this is why we offer the air testing as another sentinel test. Just a few facts here that are backed by literature. Half-life in air, about 2.7 hours. Exhaled breath may emit up to 1 million copies or so. What we don't know is how many virus particles it actually takes to make someone sick. So the infectious dose is yet to be determined. That'll be very helpful once we know that. Just to reiterate, where do we apply the environmental tests? Really, any indoor environment where SARS-CoV-2 is expected, we can use the environmental test and kind of complement or supplement what we're doing with the clinical testing. So our goal is to provide as many tools to make it as easy and as efficient as possible for you to get this under control and help us to fight the fight against the COVID-19. And with that, I'm gonna turn it back to Genevieve. Thank you.
All right, thank you to all of our speakers. Now, before we move into our Q&A session, I'm just going to launch a quick polling question onto all of your screens. So that polling question should be showing up on your screen now, and it is, do you want a Eurofins representative to reach out to you regarding services discussed in this webinar? Select your answer on the screen, and I'll leave the poll open for a little bit before we move into the Q&A portion. If for some reason you are unable to select an answer on this screen but want to submit an answer, you can submit it via the question tab on your GoToWebinar sidebar menu. So while I'm letting those answers come in, I also want to remind you that everyone that's registered for today's webinar will receive a copy of the presentation, this recording from today, and the slides, and that'll be via email within the next 3 business days. If you know somebody that wanted to attend and they weren't able to, the recording will also be available on our website, which will be linked in the next slide. All right, so I'm going to go ahead and close that question. And we're going to move into the Q&A portion. So to submit your question to our speakers, go to your GoToWebinar sidebar menu, select the Questions tab, type in your question on your keyboard, and then hit the Enter key to submit. So I'm going to start with our first question, and that is, what do you recommend for getting a baseline idea of COVID-19 prevalence? If any of our speakers could chime in and give some ideas of where someone can start if they're trying to just identify prevalence in their workplace.
Well, this is Brian Dillon. So what we've seen employers do is it depends on, if you have more, I'd say your leadership or in the school, the staff, people that have a lot of contact with other individuals, they may choose to test that cohort first and then identify if those people with a lot of touch points to the rest of the workforce, any of them are detected, which kind of gives them an idea if it's more prevalent in the rest of the workplace. So good examples of that is testing staff every week as opposed to the entire student body, or at manufacturing plants or other organizations testing your supervisors or your team leaders that are working with those cohorts, but not specifically the entire workforce. So I've seen that as a strategy.
Thank you, Brian. So our next question is, what considerations should I take into account when creating my COVID-19 control program?
This is Matt. I can jump in on that. I mean, number one, that you have the required regulatory framework. I think the most important piece of that is defining your communications so that you're getting information timely and in complete fashion, and you're also delivering it back to your staff. I would put a lot of thought into how you're going to communicate, and clearly also what your first steps are going to be if you have an infection in the workplace. And then given the rules that are in place, obviously having a testing plan worked out in advance is going to be critical so that you can move quick. From my experience, getting really fast results is more important than almost anything, because you find yourself waiting for those results before you can really make any meaningful decisions on next steps with others in that same working group.
Excellent, thank you. Okay, our next question is, do self-collection tests follow the OSHA requirements for testing?
I can feel that too. I mean, OSHA doesn't have a requirement beyond telling you have to test, and this is Cal OSHA, and I believe Brian covered there has to be an EUA, and it has to either be a PCR or antigen test. And in terms of the Eurofins kit, it is a PCR test and there is an EUA, so it would be compliant.
All right, thank you. Okay, so our next question is, are any of the monitoring tests described at the end of the presentation required under the Cal OSHA standard?
No, not to my knowledge. And those are all tests that don't fall under the emergency use authorization. So those tools are just to help you deal with the actual contamination on site or in the building. And again, it may be helpful to do some of those preventatively. Like, for example, if you do the worn mask testing, there's no requirement that this has to be reported, neither one of the environmental tests. So if you can detect it and address it as early as possible, that's really where the environmental testing routines come in, and just keeping the environment clean and keeping the detecting it in populations early on before the actual clinical testing and requirements kick in.
All right, thank you. Okay, so our next question, if you have a major outbreak at your workplace, what immediate steps should you take in controlling the spread?
Yeah, I can field that one, and this, I'm going to start by just emphasizing the need to do some pre-planning so that you can get to a place where you can take some action. It's really, really important to have a means to track who is having contact with who in a work environment. And you might do that by saying group A just stays within a certain defined area, no one else goes in that area. Or maybe people keep a log. There's also electronic tools out there that can do that for you. That way you can start to evaluate the risk profile of each person that's left standing, so to speak. Because obviously anybody that's had close contact with one of those infected parties needs to be removed from the work environment per the California regulation. So I think that's the biggest thing, being able to evaluate who has had that close contact and immediately get them out of the environment.
Okay, thank you. Okay, so before we end, are there any final thoughts that you would like to leave our audience with?
Yeah, I would like to reiterate this idea of the layered approach that we can take to address the situation. And obviously, the clinical testing, I think, is the main component of any program that you will have. But the other tools that we can offer can help you put several layers on the risk mitigation and avoidance in place. And again, we're talking about policies, we're talking about social distancing barriers, we're talking about ventilation, and then we're talking about testing environment as well as people. And, that's the point I wanted to make also again.
Excellent, thank you. All right, thank you so much to our speakers for sharing their expertise with us today. Thank you everyone who was able to join our webinar. Just a final reminder that you'll get a copy of the slides and the recording via email later this week. And have a great rest of your day. Thank you.
Thank you all.